Welcome to Eyes on Tomorrow, supported by Topcon Healthcare
and TEA UK.
My name's John Ferris, ophthalmologist.
And my name's Dermot Keogh, optometrist.
So Dermot, really excited about a year of podcasting ahead of us. And one of the major themes of many of these podcasts is going to be the role of artificial intelligence and how it's going to shape all of our working practices. I must admit, having done a lot of reading before our conversation with Pearse Keane, I now think really how woefully inadequate my knowledge was of AI as applied to ophthalmology. I've read Mustafa Suleyman's book, The Coming Wave, but even that didn't really prepare me for the impact his work is going to have on our working lives.
John, I was the very same. I really thought it was all about ChatGPT.
Which we all use.
But I didn't realise the years of research that's gone into this. And I think what we've learned is how it's going to impact global health in the coming years.
No, absolutely. So we were so pleased to have Pearse kicking off 2026. We wanted this podcast to be an overview of the scope of the work and an introduction to the enticing and exciting possibilities that offers all of us involved in healthcare.
So don't forget to subscribe, as you will have access to the monthly newsletter and the bonus audio.
And the bonus audio this month is Pearse talking about the world's first foundation model in medicine, RetFound. And the newsletter will include some of his landmark papers on AI in ophthalmology. So we hope you enjoy the episode with Pearse. Here we go.
Today we're joined by Professor Pearse Keane. Pearse is Professor of Artificial Intelligence at UCL Institute of Ophthalmology and a consultant ophthalmologist at Moorfields Eye Hospital, London.
And in 2025, Pearse was awarded the prestigious Gabor Medal by the Royal Society and was also elected to the National Academy of Medicine in the United States. Pearse, very warm welcome to Eyes on Tomorrow.
Pearse, welcome. So Pearse, before we get in, we're just going to go back to those early years. Tell us a little bit about what the young Pearse was like, and if you were a little bit of a techie person in your teenage years.
Gosh, how far back to? Well, first of all, thank you for inviting me to speak. It's I'm looking forward to the conversation, and secondly, how far back do you want me to go? I guess I should say, Dermot, I'm from Dublin. Grew up in Clontarf on the north side of Dublin. When I was 10 years old, moved to Sandymount and in the south side.
Moved to the posh side of the city.
Yeah.
You're a D4 boy.
You might. So I'm happy that you guys know the significance. I actually am from Dublin 4, and so yes, that shaped me. So I went to med school in Ireland, in Dublin. I went to University College Dublin. So I was there. Graduated in 2002, which is crazy to think that is more than 20 years ago now since I graduated from medical school. I come from a medical family. My dad is a recently retired consultant in Dublin. My aunt is a GP in Belfast. My uncle is a GP in London. So very medical family. My sister's a consultant psychiatrist in Dublin. So I guess that's my background. I began my training in ophthalmology in Cork and in Waterford in the south of Ireland. And then I went for a couple of years to Los Angeles to do research training. And then since about 2009, I've been in the UK.
I was interested in your previous podcast to hear, not maybe for the first time in your life, it was the cold email strategy. You did it in Baltimore as a med student, and you did it again in LA. And I always encourage my trainees to do this. So if you don't ask, you don't get. So that was the first really cold email to LA to line you up for that period of research.
Yeah. So I'm a big proponent of just getting in contact with people. And as you said, when I was a medical student, this was like 1998, 1999, something like that. And email was still relatively early and websites were still relatively primitive. I just remember reading some kind of like popular science magazine. And I remember buying it in Eason's in O'Connell Street in Ireland, and I don't know if that's still there anymore, but we basically I just read about bionic eyes. There was an article about bionic eyes, and I went on the internet, searched up the professor in charge, and I found his email, and then I sent him an email. And this is a guy called Mark Humayan. He's a vitreoretinal surgeon. And so I emailed him, and to my great excitement, just like a couple of hours later, there's like an email back from this professor in Johns Hopkins and the Wilmer Eye Institute, head of this bionic eye project, saying, sure, come on over for the summer. And then I spent the following summer in Baltimore doing research on bionic eyes. I wasn't really doing anything of any value or substance whatsoever, but like to me, it was like my first sort of step into this world, and my first evidence that if you contact people, you can do big things.
No, absolutely. So when it comes to AI in medicine, it's going to impact every specialty. Can you just explain why ophthalmology is so well placed to ride this wave? What sort of sets us apart from other medical specialties?
So I think there's two things. So the first thing is that historically there have been a number of large ophthalmic imaging data sets that have been made open source. So a number of French and US diabetic retinopathy, retinal fundus data sets were just made available to the world. And so as the AI, the machine learning boom started to take off, computer scientists all around the world were looking for medical data sets, and they basically just take the data sets that they can have easy access to, and they start to use them. And it turns out that gave ophthalmology a huge head start in terms of this space. Maybe that's something that we'll come on to later in the podcast, but I do think that actually the more that we can make data available, the better, the quicker that we can get to patient benefit in some of these things. So I think that historically those data sets gave us a head start. I think going forward, the fact is that ophthalmology and optometry is a specialty where you can image almost every part of the eye with exquisite detail, whether it's the retina, the optic nerve, the anterior of the eye, the orbit, etc., etc. And so that really facilitates things because AI is very, very good at dealing with high dimensional data such as imaging. And so, yeah, I could go on, but maybe I'll stop there.
So I was interested in the story 2016. You're reading Wired, you're reading Mustafa Suleyman's article, and probably the best £20 you ever spent in your life was for that 1 month subscription to LinkedIn Premium. You didn't want to do it for a year. So you're just going to be able to message this guy directly. Tell us about that. It was a bit like the cold email back in the day. This was the sort of modern equivalent, really, wasn't it?
Yeah. Well, so I had done the cold email when I was a medical student to go to Baltimore, and then I had done another cold email to go to Los Angeles to work for a couple of years in the Doheny Eye Institute as a research fellow. And so then I was kind of on a roll then a few years later. I was thinking about cool stuff. And so actually I had previously, I don't know if I've talked about this as much, but I had previously been interested in virtual reality and augmented reality. And I had actually sent some cold emails to the senior people in Microsoft to try and see about working with them on their HoloLens technology. For a variety of reasons, that didn't pan out. But it's probably for the better because actually I got interested in deep learning, and I had thought to myself, who can I approach within the university who can help me on this? And so I approached a couple of people within the university and from other universities, and to be honest was met with shoulder shrugs to a large extent. And so then I just figured I need to contact someone within industry. And who do I know in Google or Microsoft or Apple or Facebook? And I was thinking, I knew some people who worked in an Apple store. I knew some people who worked in Google. Like, how was that going to work? And I couldn't send a cold email to Bill Gates. And so actually, I read Wired magazine in July 2015, and I just read the profile of DeepMind, and I saw the connections, the fact that they were based in London, the fact that two of the three founders were graduates of UCL, the fact that Mustafa Suleyman, his mother was an NHS nurse, the fact that they were from North London. I live in North London, in Finchley, and Demis Hassabis and Mustafa Suleyman were both from here, and Demis went to school in Finchley in the local comprehensive school up the road from me. So I thought these are the perfect people to contact. Yeah, yeah.
And they got back to you really quickly. You said it was a bit like your experience with John Hopkins. It bing, the message straight back, pretty much.
Completely, completely. So I still have the messages on LinkedIn. I can reread them. I've got it saved and everything, maybe for like some future historical record or something like that. But um, so immediately, and I found myself then just a few days later in DeepMind's headquarters in King's Cross, and I remember at the time they send you the invitation to come, but it was in a place in King's Cross where they didn't have like any name above the door. It was like being invited to a nightclub or a bar that didn't have a name, that was like invite only and stuff like that. And so I just remember going there, and that was my first encounter with this world outside of medicine, this world within tech. And I remember sitting opposite Mustafa Suleyman, and he was asking me all these questions, but he had his laptop open in front of him, and he was like typing the whole time as he's talking to me. And this was my first time interacting with someone when they're doing this. But that interaction then led to this collaboration whereby basically 6 months later, maybe up to a year later, we were able to put in place a collaboration agreement between Moorfields and Google DeepMind, and that involved sharing about 1 million anonymized OCT volume scans with DeepMind and working together to develop a medical AI project. And of course, at the time, I didn't realize what a big deal that was, because this was a big deal from a technical undertaking, but also a big deal from like just a public undertaking, because this is sharing NHS data, routinely collected NHS data, with a company, and not just with any company, a company that is owned by Google, and not just to do anything, but to develop artificial intelligence, which in some people's minds can be quite a scary thing. And so this sort of very appropriately brings up all sorts of questions around data protection and patient privacy, and also very appropriately brings up a lot of questions around value to the NHS, and are is the NHS being taken advantage of, and so on.
Yeah, absolutely, absolutely. But your first sort of groundbreaking paper, that's a proof of concept, the Nature Medicine paper 2018, looking at the algorithms you created, grading diabetic retinopathy. Tell us a little bit about that, because that really was got people's attention, didn't it?
Well, so the focus of our first algorithm was really on macular disease, so including diabetic macular edema, wet AMD, but the full range of macular disease on OCT scans. And the big thing, and part of the reason why I'm excited to talk to you both, but particularly Dermot, was that from the start, the emphasis was not on helping retinal specialists to do stuff, but actually how we could help community optometrists, and how we could bring world-class expertise out of places like Moorfields into the community. So the idea at the time was, and still is, that you would go to your local optometrist and you would have your OCT scan, and you would have a world-leading AI system that assesses the scan, and then that would help with the referrals to the hospital eye services. Because around that time, in 2016, for example, I happen to know that we had gotten about 7,000 urgent referrals from the community as query wet AMD. And the problem was, out of those 7,000, only 800 of those actually were wet AMD. And the other problem was, and I can probably talk about this now because it's a few years later, but that the average time between referral and treatment at that time in Moorfields was 40 days. And so, as a optometrist in the community, you're thinking that you're doing the best for your patient by saying refer urgently to this. But actually, because so many false positive referrals are coming in, instead of being seen and treated within 2 weeks, sometimes these people are waiting for 40 days. And so this was what this AI was there to solve, is to try to prioritize those people with the most sight-threatening macular disease and get them in front of the right person at the right time.
I mean, that's a great point you've raised, because as you know, once technology comes along, Pearse, it's all very fine, but unless you're trained and skilled, you end up, as you correctly said, over-referring, don't you really? So, but I think that brings us on nicely to this word oculomics, which we're probably here to talk about, and brings all of this information together. I mean, I appreciate you've accredited Alistair Dennison with this word in the past, but I think we all know oculomics has been around for a very, very long time, over a century, you know, with the ophthalmoscope. And that's where we were able to look into the eye and assess systemic issues. But of course, now we're in 2026, we have advanced OCT, OCTA, high-res photograph images, and now we have, as you said, AI algorithms pulling it all together. And this is the basis of oculomics. Could you tell our listeners what this means and the connections between the eye and the systemic disease, please?
Well, Dermot, I think you've already summed it up pretty nicely, but we've, as you say, we've known for more than 100 years that you could use the eye as a window to the rest of the body. So we could detect signs of like very bad kidney disease through malignant hypertension even 100 years ago, or we could detect signs of anemia or other things like that. Now, what happened was in about 2018, there was a paper from Google. I wasn't directly involved with this paper, but this paper essentially got all of the data from UK Biobank, the retinal imaging data from the big UK Biobank study. And it applied AI, a type of AI called deep learning, to the retinal images from UK Biobank. And it tried to predict a variety of different things. And the interesting thing was that it was able to look at a retinal photograph, and it was able to predict the age of the person to within 3 years. It was able to predict the biological sex of the person with uncanny degree of accuracy, but it was also able to predict whether they smoked or not. It was able to predict high blood pressure and a variety of other things. And so this got, initially people were just thinking about the cardiovascular prediction, but actually I guess one of my indirect contributions was that I was at a conference in the US around the time this came out, and I stood up at the conference, and I remember I wasn't involved in this research, but I said the thing that is most stunning about this is that it could tell whether you're a man or a woman directly from the retinal photos, and that's stunning because we can't do it as optometrists or ophthalmologists. We can't do it ourselves. And so this suggests that there's a lot of biological information that's locked in these images. And so I said this, and the person giving the conference, giving the lecture, is a very famous guy called Eric Topol from the US, a cardiologist, and then he tweeted about it. And then it seemed to get lots of traction, and then people started talking about it. And then, as you said, a year or so later, my good friend Alistair Dennison coined the term oculomics, and we've been exploring that ever since.
And the Alzheimer's studies, it was one of the So again, groundbreaking collaborations where you were looking at hospital episode stats, looking at the Moorfields, data set, 350,000 plus patients, and then linking that to not only Alzheimer's but maybe schizophrenia, Parkinson's, other things. Can you tell our listeners a little bit about the Alzheimer's study?
So the background is, because of the success of the collaboration between Moorfields and Google DeepMind, we had learned a lot about data infrastructure from a technical perspective, and we had also learned about data protection and data governance. And so that then meant that we were in a position where we got the idea, could we link all of the data with Moorfields with the national database of hospital episode statistics, as you've said? And that was initially, at the time, that was held by NHS Digital. That's now part of NHS England. And so actually, the way that I had gotten this idea was, I was on a train from Manchester. I was at an NIHR event in Manchester, and I was getting the train back with a professor in Edinburgh called Manu Shankar Hari, who's I think an intensive care specialist. And he told me that in intensive care, they had figured out a way to link intensive care data with this national database. And then I just got the idea, why don't we do this for images, ophthalmic images? And so this was, I guess, 2017. And we got a small grant from Fight for Sight in 2017 to support this for about £15,000. And then we began this journey to link all our data at Moorfields with hospital episode statistics. It took us about 4 years to be able to just make that linkage. But once we had that, we were then able to say, any person who's had an eye scan at Moorfields above the age of 40 years, if they have gone to any other hospital in the country and been diagnosed with any other systemic disease, we have that linkage. And that is essentially the Alzheimer's study.
Yeah. One of the people that we spoke to last year was Robin Geimer, was talking about geographic atrophy, and the role of complement to certain sort of chromosomal elements to it, but also then the link between the complement pathway anomalies with retinal disease, geographic atrophy, AMD, but also with Alzheimer's and other CNS problems. I mean, are we seeing manifestations of that sort of metabolic pathophysiology in the OCT imaging that links the two together? Obviously, the brain and the eye from the diencephalon embryologically the same. What's your sort of feeling on how you link oculomics with proteomics, with the transcription things? How does it all fit together? Are we just seeing the imaging of these pathophysiology changes within the retina? Is there a link between them?
Well, so I'm not sure that I have immediately a super intelligent answer to that. But I might talk around it a little bit. But I think that more generally there has been a number of research papers. There's a big review article that came out last year about the overlaps between age-related macular degeneration and Alzheimer's disease, and sort of the way that these are interwoven. I think we're still in the very early stages of teasing out what that means and the questions that you asked. So although we have OCT images, which are of course very high resolution images, they're still relatively crude in their ability to get to the bottom of some of the molecular questions that you've asked. And so it's still crude, I would say. And a lot of what I spend time thinking about is how we can take it to the next level through other data collection. And that could be, we collaborate with a team in Harvard led by a Portuguese ophthalmologist called Inés Lanes. And she has been collecting proteomic and metabolomic and genomic data on her patients with AMD. And I'm interested in how I can support someone like her to do the analysis of their images with AI to try and tease that out. But we don't have the answers to those questions.
It's just something, obviously, that collaboration, those steps are in motion already.
Go on.
But just to say, what I would love is to figure out a way in the future that imagine if everybody coming through the door in a place like Moorfields, they give a little sample of spit or a little, maybe it's a small blood sample or something else like that, so that we can actually get all of this other rich omics data and combine it with imaging. And I feel like if we can do that, that will be the key to unlocking AI for drug discovery in the coming years.
Eyes on Tomorrow is supported by Topcon Healthcare. Imagine if a single non-invasive eye scan could unlock deeper insight into the holistic health of your patient instantly. With the Harmony connected care platform from Topcon Healthcare, that future is already here.
Harmony automates your workflow end-to-end, bringing all your devices and data together with vendor-inclusive worklists, unified viewing and seamless tools for second opinions, referrals and teleconsultation.
And now, Dermot, Harmony opens the door to powerful AI marketplace. Access-proven AI algorithms from Retinal Eyes, OptAI and INUK for fundus-based disease detection. And the newest breakthrough, Toku Eyes, using fundus images to assess cardiovascular risk and biological age.
So these AI tools deliver fast, confident, clinical decision support so you can focus on what matters, your patients. And behind the scenes, the Topcon Healthcare Innovation Centre, Think, invests in leading oculomics startups, accelerating development, validation and commercialisation directly through Harmony, where connected care meets the future of oculomics. In the prediction of these systemic diseases, Pearse, what are the potential sources of bias? As we know from these large language models, garbage in, garbage out. But what safeguards are going to be in place?
Well, so I think generally when we talk about applying AI in medicine, I think we're always conscious of the bias issue. And the shortcoming of pretty much all of these machine learning systems is that they're very good when they're deployed on data that's similar to the data that they've been trained on, but they're not good if it's something different. And so if you've trained your AI system on images from white Irish men in their mid to late 40s, then actually it's probably not going to work on a totally different demographic group. And so I think.
And so how do you see this
we
evolving?
just have to be aware.
Yeah.
Yeah, so I think we have to be I think the first thing is just being aware of those limitations and documenting those limitations. So I think it's very, whenever we develop an AI system, I think we have to be very transparent about the data that it has been trained on, so that people can already begin to see whether there is shortcomings. And also we have to test it across different ethnic groups, across different disease severities, across different populations. And the challenge, like, we want these systems to be fair, but ultimately we also realize that there are certain eye conditions that are more common in white Irish people and certain eye conditions that may be more common in Black African patients. And so we also have to disentangle those aspects also.
Yeah. When it comes to consent, another sort of area of concern, if you're an optometrist in practice, we've got the ability for color fundal photographs, OCT, with all this potential hidden information. What sort of do you think the challenges are when we are eventually using this more in clinical practice to consent patients? Because although there's many advantages to early diagnosis and risk stratification, potential downsides, life insurance, and those sorts of that data protection for the individual patient, because we are potentially sitting on a mine of information, some of it useful, but some of it people might prefer not to know about. And if you are the person doing the investigation, you've got that information, how much are we obliged to share with the patient? What should we be telling them before we do the imaging?
So I think when we talk about the ethics and the consent for AI in ophthalmology or in optometry, I think we need to differentiate between the development of the algorithms versus the deployment of the algorithms. And so I think what you're talking about is a little bit more around the deployment of the algorithms. I think that there's already pretty strict regulations about how you can use AI. So if you want to use an AI system in clinical care, that counts as, in regulatory terms, which is called software as a medical device. So you have to have, for example, in the US, FDA clearance, or in Europe and the UK, the relevant European clearances to be able to use those systems on patients. And then when you use them, those have very specific intended uses. So you might have an AI system that does diabetic retinopathy screening, and you may or may not have to get consent to use that on a patient. But that system is not going to just spit out, oh, this person also could have Alzheimer's or something like that, because that's a whole other can of worms, and that would have to go through that would have to be considered. What are the ethical implications of that? What are the regulatory implications of that? That's not going to happen anytime soon, I would say.
So, I mean, really, all of this is massively exciting, isn't it? Because as you kind of said earlier, optometry is uniquely placed, aren't we? I mean, optometry is really, in a sense, their role will change, won't it? We're not just going to be optometrists. We'll be healthcare clinicians. It'll be a redefinition of our role in one sense.
It's worth zooming out to think about what is the future of healthcare across all medical specialties. So my title at UCL is Professor of Artificial Medical Intelligence, and so I'm interested in this concept of artificial general intelligence that you hear people talking about in the AI world, AGI, and AGI is. Essentially, there's lots of different definitions, but one of them is like when you have algorithms that are as good as most humans at most cognitive tasks. And so I'm interested in what happens to healthcare as we start to get AGI in healthcare, artificial medical intelligence. And I think that is really going to cause a big shift from the hospital to the community. So I think that a lot of the future of healthcare is going to be general practice. We'll say, leaving aside eye care, is going to be about GPs. And I think when you go to the GP in the future, the GP is going to be much more empowered to do things like someone comes in and they say they've got like a irregular heartbeat. The GP will probably be able to take out an ultrasound probe linked to an iPhone, put it over someone's heart, and then get an echocardiogram, but be able to interpret the results without being trained as a cardiologist, because the AI system will be able to give them the outputs. Or you can think of that for almost any medical specialty. And then in that scenario, only a much smaller percentage of things actually need to go to a hospital setting. Now, in an eye care perspective, of course, the primary care in eye care is optometry. And so I just think that the future of eye care is going to be much more empowerment of optometrists around the diagnosis and the monitoring of much chronic eye disease. And only, like, imagine if you're someone with glaucoma. I could imagine that much of the care of people with glaucoma will be done in a community setting and monitored in a community setting. And then you only go into the hospital if you need your glaucoma filtration surgery or something more complicated than that. That's the way I would see things.
That's turning it on its head, though, isn't it? That's going to take quite a shift in thinking in hospitals, isn't it?
Well, to a degree, but one of the points you made at the start, Pearse, was the AMD referrals. You're getting 8,000 referrals, only 700 of which actually had wet AMD. I'm the same in my neuro-ophthalmology referrals. I've 350 query swollen disc referrals, which I whittled down to 60 we actually see using a combination of colour funded photographs and OCT. So you keep it in the community, and you don't need to worry about that. That's fine, just monitoring them. So it's freeing up secondary services to do what they really need to be doing and making it better for patients. They don't have to go to the hospital. So I think that's the big plus, keeping it in the community, be it general medicine with your GP, with your optometrist, and freeing up the hospital to actually deal with the stuff that really needs to see an ophthalmologist. I think that's the massive potential boom, with AI.
100%. And if you throw in, then I guess the wild card, Dermot, is the oculomic side of things. Where does that where does that come in? And so you could. My prediction for that is that there will be a lot of things that we find that are useful for oculomics, but I don't think it's going to be a magical thing where we can just say, oh, this person is going to develop Parkinson's disease 10 years from now or anything like that. I think that the tools are too crude for that. But I could imagine a situation for something like, imagine you're like a 35-year-old guy, you don't go to your GP that often or never, and you go and you have a retinal exam done, and the retinal exam gives some measure of like high blood pressure or some measure of like pre-diabetes or something else like that. And then that triggers then a referral by your optometrist to your GP. I could see a lot of that happening in the future.
Yeah. So really, we're talking about a much more collaborative approach between optometrists and our local physicians, really. Yeah. Great. Well, I mean, it's been, we like to end on a nice, jolly note. We used to talk about people, what you did in your spare time, but we've got a few quick fire questions for you this time, Pearse. So we're going to ask you whether you prefer hurling or football.
Oh my God, I would say hurling. Hurling, I used to play hurling in Oatlands College in Stillorgan. I was never any good, and I was terrified most of the time.
You still have all your teeth, though, with
players,
I was never good either, anyway.
I still, and they kept telling you, like, if you're scared, that's more, you're more likely to be injured. But like, I didn't find that to be very advice.
Guilty pleasure box sets and all that free time you don't have, Pearse. If you had to say what go-to viewing, your Netflix, you're thinking, really, what sort of genre?
Oh my goodness! I want to try and say something interesting and not say something like kind of hate or something like that. No, well, I guess
Are you a slow horse?
I mean, probably some of the classics like The Wire, The Sopranos, those types of boxes as well. Or I like I do like, if I have the time and the energy, more like popular science type stuff as well. Like
so
that.
Are you an early start or a late finish man?
Or both?
Or both.
So I feel like pre-children I was a late start, and now I've got two daughters, an 11-year-old and a 7-year-old, and then we got a pet dog last year, and now I'm an early like 5 a.m.
Join the club.
City break or west coast of Ireland, country walking?
Oh, I think I would traditionally always have said city break, but I do, maybe I'm getting old, but I do now like the idea of just going to the West Coast and just going for a long walk and listening to an audiobook or chilling out or thinking about deep philosophical thoughts.
Listening to one of our podcasts, I'm sure, Pearse, is what you're doing. And finally,
yes, of course.
One thing you'd wish you'd known maybe earlier in your life.
So I think maybe this is not one thing, but I do generally think that in medicine, it's such a long and drawn out and very hierarchical career where you have to just basically do as you're told until you're like nearly 40 years of age. And I kind of, maybe this is just an observation, but I really liked becoming a consultant and having some autonomy and being able to see my own patients over time myself and not rotating and not having to, be in a hierarchical system. And I could, when I look back now, I think I could never go back to being a junior doctor or a medical student and go through all of that again in the way, because I know what it's like now on the other side.
Yeah, brilliant. I think, Pearse, a lot of the things you've been talking about, so if you've got a trainee, be the optometrist or ophthalmologist listening, should take heed of the fact that on many sort of crossroads in your career, you've made decisions or choices or just taken a punt on something to see what happens. That's why I say to all my trainees, you think you're going to go in this linear path in your career, but opportunities will arise and you think, will I go down that road? And you end up having this multifaceted career. You're going down avenues you never thought you'd go down. You're sort of living proof of the benefits of that open mind and actually think, I'll try.
Yeah.
I was listening to a podcast from Rory Sutherland yesterday or the day before, and he was talking about this very point, that you have to keep your options open, you have to take chances. I think he was talking about optionality, and he was talking also about actually when you look back, there's only a small number of things that happen in your life that can have profound influences. So for me, reading Wired magazine in July 2015 and contacting the co-founder of DeepMind, that is something that changed my life. Another thing that changed my life was when I went to Los Angeles, I was planning to stay in the US and try and continue my career there. But I bumped into an Irish guy called Tom Flynn at Arvo in 2008. And I just bumped into him on the conference floor. And from Cork, yeah. And he told me he was doing a PhD in UCL at the time. And he told me about some clinical academic opportunities in the UK. And just from that one meeting, I switched my entire life. And now my kids are born in England, and I'm probably going to live the rest of my life in the UK.
But it's these sort of, it was a chance conversation with Nigel Kirkpatrick, a guy I went to school with, one of the chaps who set up New Medica. I was a third-year medical student. I said, what are you going to be doing, Nigel? He was 4 or 5 years ahead of me at school. Ophthalmology. I said, why ophthalmology? Great medicine, great surgery. I thought, that's interesting. And that one conversation with Nigel was the reason I ended up doing an elective. Totally changed my life. I don't know if you've read Malcolm Gladwell's Outliers, but it's that sort of thing that you just, that one conversation and a couple others along the way, random things that have totally defined the direction that I've gone in. It sounds like the same with you. Pearse, it's been absolutely fantastic having you on today and to giving us this tour de force, this overview of AI, not just ophthalmology, but medicine in general, primary care, what we've got to look forward to.
Yeah, it's been great, and I think you've given great excitement to all optometrists listening that, there's more to come for us in the future. And I hope there'll be more from you, Pearse, because we'd love to have you back, because I'm sure we'll have many more podcasts to fill, John.
Absolutely.
John, so really following from this podcast, I think what is really, really clear is that how large language models are becoming a hugely beneficial tool in global healthcare.
But there are, as Pearse pointed out, there are Dermot, thorny issues which will arise as a result of these equity of access, ensuring they are reflective of the wider society, data protection issues, and as models begin to predict systemic and neurological disease, the need for clear guidelines and training.
But how exciting. As Pearse said, optometrists will now be they're uniquely placed really to be at the forefront of community healthcare.
Yeah. And then the links also to hospitalised services, to GP services. So it's really going to change the entire scope of optometric as well as ophthalmological practice. So we really hope you've enjoyed our conversation with Pearse today.
And if you have enjoyed it, don't forget you can hear us on Spotify, Apple, or wherever you get your podcasts.
And as we said at the very start, please don't forget to subscribe to us on Eyes on Tomorrow at substack.com for access to the monthly newsletter, perfect for your CPD, and to the bonus audio. I'd like to finish just by thanking our sponsors, Topcon Healthcare
and Teo UK.
And a big shout out to Matt and the team at Rethink Audio for producing the podcast. Until next time, it's goodbye from me.
And it's goodbye from me.